So if we now start looking at patients with type 2 diabetes, remember DAPA-HF and DEFINE-HF are different studies because they look at patients with heart failure regardless of diabetes, right? So if we're now going to say, how do we take this data and apply it to patients that have type 2 diabetes, I think what we now know is that in these very high-risk patients for cardiovascular complications, remember that cardiovascular disease is the #1 cause of morbidity and mortality in people with type 2 diabetes. We now have 2 classes of agents that are highly effective in improving cardiovascular outcomes, including SGLT-2 inhibitors and SGLT-1 receptor agonists. Very different effectiveness profile. So with GLP-1 arrays, primarily what appears to be an effect on atherosclerotic vascular disease progression. So the main benefit appears to be reduction in MACE, what we call 3-point MACE, or major adverse cardiovascular events, which are myocardial infarction, strokes, and dying from cardiovascular disease. And the effect emerging after several months of treatment, which goes along with atherosclerotic effect of that class, which appears to be anti-atherosclerotic effect, where with SGLT-2 inhibitors, while they do also modestly reduce the risk of major adverse cardiovascular events, or MACE, the place where they really shine is in prevention of heart failure and progression of chronic kidney disease. So multiple trials, both cardiovascular and kidney outcome trials, now showing that these drugs effectively prevent heart failure in people with type 2 diabetes and effectively prevent progression of chronic kidney disease. And those 2 effects, prevention of heart failure and chronic kidney disease, appear to transcend the patient's, where the patient is in terms of the spectrum of risk. So whether you're a really low-risk patient that has normal kidney function, or whether you're a really high-risk patient with significant chronic kidney disease and albuminuria, these agents appear to be, from a relative risk reduction standpoint, as effective in preventing the progression of kidney disease and also preventing heart failure hospitalization. Now, of course, if you already have established kidney disease, your absolute risk of kidney disease progression and actually heart failure as well is much higher. So the absolute benefit is greater and the number needed to treat is lower, but the relative risk reduction is exactly the same and very, very consistent across the entire spectrum of risk.